other part of that healthcare team. You have the primary care physician, you have the neurologist, possibly you have, the pulmonologist, you have social work, you have pharmacy. Palliative care really is this interdisciplinary team that pulls all of those members together to say what is most important and how do we put a care plan in place about what matters most to this patient. So I will say, as I said, that patient really equals everything about that patient and family, right? So that includes that caregiver, that includes, children, grandchildren. Again, when people get sick or get a new diagnosis, as we know, in speaking personally in my own family, that affects the whole dynamic of the family. There can be emotional stressors, financial stressors, lack of resources. Maybe a patient needs more care at home and family's unable to provide that. So, as we see all of those changes happening, that's the world that I live in palliative care, is how do you navigate all of those things? And medicine is so specialized nowadays. And what I find a lot with patients and families is they'll meet with the cardiologist and then the endocrinologist and then the cancer doctor, but nobody's pulling all of that together for them to say, okay, let's look at all of those specialists. What are they saying? And then let's put that all together and say, what does this mean for you? What's the most important thing to you? What are your goals? And how do we make that happen? So that when we're creating a plan of care for a patient, whether that's medication, whether that's outside resources, whether that's alternative things like pet therapy and meditation and massage, that's such an important component of palliative care, that we're doing it in the context of the patient, that patient and family. It's so very patient and family centered.
So, excuse me, is it actually providing care, or is it more navigating the system that that palliative care is? Like, is there a
Sure.
care component, or is it really just kind of helping people navigate everything?
No, so there's a care component as well. So as a nurse practitioner, so when I go in, I'm managing symptoms. So I'm seeing
Mhm.
patients primarily in their homes, because the types of patients that I take care of are primarily having a harder time leaving their homes. So we do home visits, and it is a full physical assessment. It's a medication reconciliation. We have pharmacy evaluating meds, prescribing meds, collaborating with the primary care. So this is not something that you would give up your primary care or your other doctors. It's really what we'd like to say an extra layer of support. There are a number of palliative care components in home health agencies. So, for instance, for my practice, which is a small business, relatively new, what I do is I collaborate with other visiting nurse agencies that have nurses, home health aides that have been educated on palliative care and can bring physical care, as you said. So if someone needs help with bathing, if someone needs physical therapy, occupational therapy, we're bringing those services in place at home.
And so, as a nurse practitioner, are you able to? Um, I know sometimes the side effects of, say, cancer treatment, you end up, very nauseous, very tired. Are you, as a nurse practitioner in the palliative care field, are you able to help people with those kinds of side effects?
Absolutely. So a lot of what I do is symptom management, one component of all of the components of palliative care, which is very holistic, but symptom management, both, and the goal of symptom management in my vision is preventing suffering versus treating it. And if, certainly we're going to treat it as well, but if we can prevent someone from a pain crisis, or we can prevent someone from nausea, knowing that this expected treatment is going to cause some nausea, how do we do that proactively? How do we talk with patients and families so that they're making informed decisions about treatment, about symptom prevention? So absolutely. And I will say, outside of prescribing medications, as I mentioned earlier, there are so many components that we can treat true symptoms that are not a medication, right? So that's music, that's meditation, that's distraction, that's home massage, Reiki, reflexology, pet therapy. All of those components are so important and really can minimize side effects that a medication might be causing, right? But you can treat it with other means. And I found those things to be very, very helpful for my patients.
That's awesome. So, in order to receive palliative care,
Mhm.
Do you have to um, stop seeking treatment for your disease? Do you have to give up your medications? Do you have to kind of accept that the end is near? Or can you get palliative care for now?
Palliative care, and this is the true component, and I think if you take anything away from this talk today, is really palliative care is appropriate at any stage of illness, whether it's new diagnosis, whether it's an illness that you've been dealing with for a few years. It does not mean you have to give up any care. It does not mean you have to shift your focus away from treatments and, onto primarily comfort. It is this great, I always say to patients, it's this gray space in between your healthiest self and your end of life. How do we maximize the quality of life in that gray space? You can still go to dialysis. You can still get your blood transfusions. You can get your chemotherapy. But bringing in palliative care as an extra layer of support to help you manage all of those things. And again, lots and lots of disease education with patients and families so that we can talk about things that might come down the road, but talk about them early. It's outside of a crisis. So people have time to think about, okay, if my illness progresses to this, I know that this is the quality of life that's meaningful to me, and these are the decisions I want to make. So again, in addition to all the symptom management and stuff, we're living and walking that journey together, to be proactive, to be thoughtful, and again, to infuse the most life, really truly living with a serious illness, because a diagnosis doesn't mean the end of things. And I think some patients can feel that way when you get a very serious diagnosis. How do we transform that into hope, life, joy, and comfort, and managing symptoms so you can really maximize the quality of life?
Wow. Is palliative care something that is covered by insurance, or do you pay for this out of pocket? Like in general, how is this covered?
Correct. So it is covered by most major insurances. Yep. And it's considered a specialty service similar to if you were to go to your cardiologist, if you were to go to your endocrinologist or your, diabetes doctor, or your pulmonologist. So you have your primary care and then you have specialists. So it is considered a specialty service similar to those other specialties that you would go. Most major insurance companies do cover it. Sometimes, depending on your health insurance plan, sometimes there is a copay for a visit, similar to if you went to your heart doctor, you might have to pay $15 or such. What I find in the patient population primarily that I've been serving with Medicare, and then a secondary insurance, often patients have no out-of-pocket expense for that. It is covered under their health insurance plan.
Wow. So, Kelly, what is your background? What drew you to this specialty? Because it is very unique and it is something that um, it's not something that everybody is drawn to. What drew you to this?
Sure. So I come from a family of nurses. So first and foremost, I grew up with a mom who was a nurse and aunts as well. So it was certainly a career choice that I was very interested in. And I will say, as a bedside nurse for many years, I worked in critical care and oncology, were areas that I worked in. And I think I saw, not think I saw, I know that I saw, people really truly struggling with serious illness and struggling with symptom management and really sort of wanting to improve that quality of life piece. And again, in my nursing career, I worked primarily inpatient. So I was seeing people very much in acute crisis. When I went back to school for my nurse practitioner and then also my doctorate, I felt that I wanted to move that dial upstream to say, how do I get to patients in the community before we get to that crisis place and hopefully avoid that crisis place, right? Get to the community and say, how can we truly live life well? How can we improve symptoms and really talk about things that we're afraid to talk about, quite frankly, right? So I think as a society, we don't like to talk about death. And I think sometimes I see palliative care gets introduced very late in a patient's disease. And that's why people think it's hospice. But truly, 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 the full benefit of palliative care is when we get involved earlier in a disease course, again, new diagnosis, and be able to talk about what that means and be able to infuse that patient into the whole focus of the treatment for that patient. What is important to you? What's meaningful to you? I've been blessed to have the most heartfelt conversations with strangers, quite frankly, patients, new patients that, priorities become very clear when a person gets a new illness or their health is starting to change. And they're beautiful, meaningful conversations. And we can take that and really, give them the best quality of life. And that's what drew me to the work, because I'm sort of fulfilled by that each day.
And it's true when you are able to have conversations that can be really difficult conversations, but that they need to be had. It is a very beautiful space to be in.
Mhm.
Is palliative care something that you can kind of come on and come off service as needed? So um, maybe your husband just got a diagnosis of dementia, or um, your wife has kidney failure, and right now you're trying to figure it all out because it's a new diagnosis, but then kind of you stabilize. Can you kind of start and stop palliative care as you need it?
Absolutely, absolutely. So it's certainly something that can be start and stop. What I like to say to patients is it's nice to be involved along that journey, even during those stabilization times. So maybe you're not seeing your palliative care specialist as often during those times, but there's still a touch point and check in. How's everything going? How are symptoms? Do you have the resources that you need? So that there is that continued conversation, right? Because it's not just meant to be, palliative care is not just meant to be a one-time conversation where you talk about, illness and life, and then you never talk about it again. It's meant to be this relationship. But absolutely, I have a number of patients, and I'm fortunate to say that I have gotten involved earlier in their course and been following for 2 or 3 years, but the rate with which I see them really depends on what's going on during that time, right? So sometimes it's a little more frequent if they're having some symptoms, and other times it's a little bit, we're in the background, we're here, you call when you need, and we'll touch base to check in. So absolutely, there's nothing like, you sign up and you can't sign up again. There's nothing like that. It's really, it's always available.
That's good. And if somebody is receiving palliative care and they're undergoing treatment, and maybe the treatment isn't working, or maybe they're just tired of going through the process of treatment, are you able to help people transition to hospice? And if they do transition to hospice, then does palliative care need to end, or can it be both?
So that's a great, great question. And I'm going to answer in two different ways, because there's what I would hope to happen and then what currently happens. So I think we're hoping for policy change in the future surrounding this. But yes, absolutely. I've cared for a number of patients that I've been involved on a palliative care perspective, and they're getting and approaching toward the end of their life. They've made decisions not to continue treatment. The hospice benefit provided by Medicare is a full comprehensive service that really pays for true end of life care, which can put services in the home such as equipment, nurses, um, uh, spiritual care, chaplains, social work. All of those things we're doing in palliative care too, but this sort of hospice benefit is very specialized and really meant to be care for when a patient has progressed to a point where they are approaching the end of their life. Um, Unfortunately, right now, palliative care takes you to a certain point, and then hospice care will take over. So Medicare does not pay for both the continuation of palliative care and hospice care. So for some, at that point, it's usually a handoff to the hospice team. What I would love to see in the future from a policy standpoint is Medicare would pay sort of for that whole hospice umbrella, so that we could get all of the benefits of what hospice care is able to provide further upstream, because I think that's where kind of we can make some really strong differences, and that we wouldn't have to stop seeing patients as they approach, because that's a hard, as you've created an emotional connection with the patient and a family through the course of a prolonged disease. It's very hard to come to that place where they're transitioning to hospice and it's appropriate and that care is appropriate and that care is going to benefit them for end of life care. But saying goodbye is a hard place. So my hope would be that some policy changes where we could continue to follow into that realm. But I will say, even though it's not paid for, do I still follow my patients into the hospice arena? Yes, as a clinician, yes, but it's not something that's typically reimbursed. Not that
Right.
patients have to worry about that. But
Right. You do that as a human being
that's right.
because you have a good heart. And that's something I noticed about you the first time we met, is that you have a good heart for this. So if somebody, is there an age group that is eligible for palliative care? Like, do you have to be a certain age, or can anybody of any age get palliative care?
Yeah, so anyone of any age. I have a colleague who works in Rhode Island, has her own practice, the Magnolia Clinic. Linda Del Vecchio Gilbert. She's a nurse practitioner and does pediatric palliative care. So palliative care truly is any age. Her practice focuses on pediatrics. My practice focuses on adults. So 18 and above are the patients that I see, and I have had patients in their 20s and 30s, unfortunately, with the diagnosis of a serious illness that were very appropriate for palliative care.
So we're hearing a lot, and I don't know if this would fall under palliative care or not, but we're hearing a lot about long haul COVID, where people are really quite sick, although no longer, say, testing like acutely positive for COVID, but they still really, they can't breathe, they can't function, and they're really struggling, and there's not a lot known about that. Is that something palliative care might be able to, or is this like still such a new thing that's all still being worked out?
Yeah, that's a really great question, right? Because I think so far in this conversation, we've talked about diagnosis. But I will say frailty and failure to thrive, types of things that don't have a particular diagnosis per se, but we have an aging patient who's losing weight, functional status, but they really don't have any any real big medical diagnosis. Does that fit into palliative care? Absolutely. Because again, it's about changing health needs. It's about quality of life. I agree that I think we'll start to see a lot with post-COVID syndrome. And I've already started to see that in my own practice and hear of it. Usually for the patients I'm taking care of, they also have a combination of other chronic comorbidities that go along with having had COVID and having some long-lasting effects of that. So that'll be an area that'll be interesting to see, sort of how those symptoms present, how we manage those symptoms in the field of palliative care. But I think, again, the goal is, no matter what the diagnosis or lack of diagnosis, if there are functional declines, if there are unpleasant symptoms that are affecting your quality of life, there may be a role for palliative care there to help manage some of those things.
And how about dementia? And dementia can be caused by so many different things. I mean, we've talked about that on several Friday Friends.
Yes.
And it can be a new diagnosis, but it can also be a really long, difficult journey when a loved one or yourself is diagnosed with dementia. Is palliative care appropriate for dementia, for individuals who have dementia and their families?
100%. 100%. Because as you said, that journey can look very different for every individual patient or family, right? Was their dementia a result of a stroke? Is it Alzheimer's dementia? Is it Lewy body dementia? There's lots of different types, and those courses can look so very different, right? You can have a patient who really kind of has a waterfall diagnosis and just swiftly declines. But what I see more often is this sort of very gradual trajectory. But a lot is changing. And what I find too is for caregivers, particularly with dementia, we always say it's a double loss, right? You sort of lose your loved one or that person. You lose who they were as a person before you physically lose them. So I will say, outside of all of the symptom management that dementia patients can benefit from with palliative care, you also have that caregiver component of, oh my gosh, how do you How do you provide the resources, the emotional support for those caregivers, as you mentioned, with what can be a pretty long journey? So palliative care is 100% appropriate. And again, we're working with the other organizations. It's not that, you're not giving up anything. It's not that we're an extra layer of support. That's what I keep saying is you're not giving anything up. You're not getting rid of any doctors or other services. It's an extra layer of support to help you navigate those things that can be difficult, particularly with dementia.
Yep. And for palliative care services, you don't have to say stop getting treatment. You don't have to stop getting medications. You don't have to one of the things I hear people are often afraid of is, okay, they're just going to give me morphine.
Mm-hmm.
That are do people have to be concerned about those things with palliative care?
Absolutely not. So again, I think that's also just the confusion, and some of my life's goal is to educate and correct that misnomer, because I think it prevents people from getting supportive service that they could really benefit from because of fear or just being ill-informed. So absolutely nothing needs to be given up. I will say, there's a lot of fear around morphine, and from a lot of patients, and I have many patients and families say that. I will say that depending on the patient's illness and symptoms, morphine has been around a very long time. It's a very safe medication, and we use it for lots of different reasons. We can give morphine after a hip replacement. We can give morphine, but most people think morphine end of life. So
Right.
again, lots of education around that. Does not mean that morphine might not be appropriate for a patient, but that indication is to treat pain or to treat breathing, or again, you're not stopping any medication when you come on palliative care. It's about reviewing and maximizing good symptom management, helping people eat better, sleep better, helping people feel less depressed, helping people have counseling to help them adjust to their illness and their disease.
And how about so Carrie Lynn had a question. Does a chronic illness that is not considered terminal fall under the umbrella? For example, Lyme disease. We have a large population of individuals here in Rhode Island because we have such a high tick population
That's true.
that are suffering from Lyme disease, like long-term chronic Lyme disease.
That's true. So would that fall under palliative care? I think possibly it could. What I would say is with certain illness populations, we will work collaboratively with other specialists as well. So I currently have a patient who has had Lyme, has some connective tissue disorder as well, sort of related to Lyme. Lots of pain and symptom management. We work a lot on quality of life, but what do is we also work with a pain clinic. We also work with other specialists who may have more experience in that patient population to really improve quality of life. So I hope that's not a roundabout answer, but I do think that there are chronic non-terminal illnesses that certainly could benefit from palliative care.
That's awesome. And so we talked a lot about the individual who may have these diagnoses. As part of the palliative care work that you do, do you really help, say, support the family members there? So, maybe, excuse me, maybe that husband has been diagnosed with Parkinson's, and the wife is like, if he just gets outside and starts exercising his legs, and he, is out there lifting his weights, he'll get strong enough, and then he'll be able to do XYZ. Do you work with the families to help educate them and help them really understand what their loved one might be experiencing, or are you only limited to that person with that diagnosis?
No, so it's the whole unit, right? It's the whole unit of the patient, the family. It really is holistic care, because again, a lot of this, as you just mentioned, is education, right? Education about what the disease course is. And sometimes not sometimes, oftentimes I will have patients or families frustrated, right, that the patient or a loved one is not able to do. Well, they're not doing what they should do, and they're not participating in therapy. And there's anxiety, and there's frustration, and there's anger. That all comes with serious illness, right? So there's a lot of that needs to, yes, we're taking care of the patient, but we're taking care of that family member who's also taking care of the patient. And we're doing education, and we're doing caregiver support nights so that that caregiver can step away and have a breath, right? Lots and lots and lots of education to say this is not necessarily a choice of the patient. This is the disease. This is what we're seeing, right? And how do we support that patient and family? It's hard sometimes, right? It certainly is hard. There's a lot of, when someone you love, there's a lot of emotion that comes up, and that can be happy and sad and angry emotion.
Yeah.
But we work through all of that together. So lots of joint family meetings. I've had many, I do family meetings all the time where we're meeting with the patient, the spouse, the siblings, and we're talking about collectively what's happening. So everybody understands where we are in the course. Everybody understands, sometimes having to give that patient a voice within the family and say, this is what this patient is wanting, or this is what the patient is struggling with.
I think that's something that is really important for viewers to hear, because sometimes the family members want to have the say on
Mhm.
everything. This is what mom is going to do. This is what, dad is going to do. This is what my spouse is going to do. And not actually have the individual with the diagnosis who's experiencing these things have their voice at the table. They almost get shouted down.
That's right. And I think so, as important as it is to hear that caregiver and hear that child say, this is what I want for my mother, at the end of the day, right, if a patient is competent and able to make their own medical decisions and be part of that, we need to be centrally focused on that patient, taking into consideration everybody's thoughts and feelings on it, right? But I've had many patients that I meet with individually. You meet with the family, and then you go back and meet with them individually, and they're telling you things that they haven't shared with their family, right? I'm tired and I don't want to do this anymore, but I'm afraid to let my husband down because he really wants this. Or vice versa. I really want to do this, but my daughter, who's a nurse, is talking me out of it, right? There's all of these sorts of dynamics. Is there one way to handle every situation? Absolutely not. There's no rule book to this, but it's really sitting and processing those things and making well-informed decisions. That's what I'm always saying to patients and families. Let's look at all the facts. Let's look at sort of what this disease entails, what the prognosis is, and let's think about what's important to you and how do we fuse those things together, right? There's not a right or wrong answer in any of these conversations. It's really maximizing the patient's voice, patient's wishes for care as they're living with, a serious illness.
And it's not hospice. So it's not a
No,
requirement of 6 months or less to live. It
no.
can be at any time.
At any point in an illness, any point, diagnosis, changing health needs. Palliative care does not mean that you're going to die in a month or die in a year. It truly, truly is serious illness with symptom management and some functional changes that are starting to happen. And how do we get in there and stabilize those things? How do we, again, talk about education, support caregivers, symptom management.
So even things like I don't know, God forbid, but if I were to have a heart attack and survive,
Mhm.
but my heart is severely damaged, so now I can't be as physically active as I have been, um, and have to make some real life changes. Is palliative care something that can really help me kind of navigate that new way of life?
Absolutely. And again, in that particular situation, I would imagine that there would be some cardiac rehab involved, or there would be, you'd have your cardiologist's office, you'd have some additional supports there. But 100% would a palliative care team or provider be able to provide some support surrounding that change, right? That new way of life. And how do we adjust to that? How do we manage symptoms of maybe angina if we're having some recurrent chest pain after something like that? Again, when a heart is diseased or has an injury and is functioning maybe less than it had previously been, right? That's a serious illness. That's a serious illness. That can become a chronic illness, and how we adjust to those things is certainly a place for palliative care.
That's awesome. And you said that through palliative care and through your services, you help families have maybe difficult conversations about getting certain paperwork done. Is there anything being done nationally to highlight the need for paperwork to get done?
That's right. There is. Thank you for bringing that up, Deb. So, April 16th is actually National Healthcare Decisions Day. So that is, and people who don't live in the world of palliative care may have no knowledge of that, but this is what I breathe, so I'm very well aware of it. So it's the day after taxes, and whoever picked that day did it very distinctively, due to, life is about death and taxes. We've heard people say that before. And as I say that jokingly, it's quite serious. National Healthcare Decisions Day is April 16th every year. And really, there is this national push and public outreach to encourage people to sit with their families and talk about healthcare decisions. I would say the most primary, most important thing is choosing a voice. If you were sick and you were unable to express what your wishes for care would be, who would that person be? So choosing a healthcare proxy is super duper important at any point. Don't wait till you have an illness to do that. I feel very strongly, you're 18 years old, you're an adult, you're going off to college, you should be identifying, if something should happen and I'm at college, who could make medical decisions for me? Truly, truly. And we're really trying to infuse the importance of that earlier in age and also into primary care settings, so that when you go to your primary care and they say, what are your medications? What are your allergies? Do you have a healthcare proxy? That's what I would love to see, because again, it's equally as important to all of those other things. So I would say that's the first thing, is thinking thoughtfully about, if I couldn't make my own medical decisions, who do I feel would best honor those wishes? And not only choosing that person, but also having a conversation with that person and or your family to say, if anything should happen, again, can we prepare for everything in the future? We certainly can't, but this is meant to be a guide to say, this is what I deem as quality of life. And if I were to have a car accident, if I were to have a stroke, these are the things that would be important to me. And this is the type of care I would want and the type of care that I wouldn't want. I think those things are equally as important. Hard conversations to have, but I think just starting to have those things so that they become a little more routine and less frightening, right? I think that's so important.
And to have everybody on the same page so that, I have my healthcare power of attorney in effect, completed. And I have regular conversations with a lot of people. And part of it is because of what I do, just like yourself. But so that everybody's really clear what I do and don't want and what isn't acceptable for me if there's some catastrophic event that occurs.
That's right.
And it's one of those things that's personal. Um, and there's not a right or wrong answer on that.
That's right. And it's meant to change, right? So I think what you want at 18 looks different than 30, might look different than 60, might look different. So there was a session I gave one time, and it said, when should you review advanced directives with patients? And they were the 5 Ds. Let me see, I hope I can remember them. One was diagnosis. So I had a
Yep.
new diagnosis. Every decade, if a patient had a divorce, so let's say a patient,
Oh yeah.
your loved one, your husband or your spouse, if there was a death,
Yep.
and the 5th one was decline, if health was starting to decline. So those are sort of just times in your life where you should maybe revisit some of those things and say, were the choices that I made 10 years ago, are they still the choices I would want now? And again, I would say they're difficult conversations to have, but having worked in critical care for many years, the grieving process looked a bit different for families who have had this conversation early on and are in the ICU making decisions about a loved one versus those that didn't, right? I think there was this place of, okay, I'm not making this decision for mom. Mom's already told us what she would and wouldn't want, and we're being her voice at this time. She's made the decision, and it's our job to bring that decision forward. Versus We never talked about this with mom. Oh my God, what do we do? Would she want dialysis? Would she want a feeding tube? I don't know. We didn't talk about it, right? Lots of both emotional situations, but very different. And I think a very different process. So in the state of Rhode Island, we call the advanced directive form, the gift of preparedness. And the reason that is if you are writing your wishes down, you truly are giving your family and loved one a gift, because they're not having to make those really difficult decisions for you. You're making them for yourself and saying, this is what I want. Please bring this forward if I'm unable to do so.
Yeah, and you can give it to your doctor too, so they already have it.
That's correct.
And that's one of those documents that a lot of times when I'm asking people, do you have a healthcare power of attorney? Their answer is, oh yeah, I have a will. No. Healthcare power of attorney. Oh yeah, it's a copy in my attorney's office. Well, that's great if something happens during the hours that your attorney's office is open, but it's actually like important that you have it handy and that the person you named has it handy.
That's correct.
Cheryl Wallison made a comment. She said, Kelly, this is all such beneficial information. I wish I had known you 5 years ago. And that's what we're working to do today, is to make sure that in 5 years, if somebody needs this information, they can say, I'm really glad I have this information.
Right.
So Kelly, if people have more questions and they wanted to reach out to you, how do they contact you?
Sure. So my email address, as well as my office phone number, but my email address is kelly@baxterpalliativecare.com. I also have a website that has a lot of information and some great links to resources, and that's baxterpalliativecare.com. And my office phone number, I do have a small office in Wakefield. As I mentioned, I see most of my patients in their homes, but this is my central location. And the phone number there is 401-400-5535.
Awesome. So if anybody watching today has any questions or concerns, or they're not sure, is it appropriate for me or a loved one, anything like that, they can reach out to you directly.
Absolutely. I have no problem talking with people about whether or not, guiding them. And if it's, let's say it's not the right thing, maybe what they're looking for is slightly different than what palliative care, absolutely have resources that I can help guide you to where you need to be.
Awesome. Kelly, I'm so glad you took the time out of your busy schedule to come and come on Friday Friends today. I think this was really important to get this information out.
Thank you, Deb. I really appreciate it. I appreciate being part of it. And Rhode Island Elder Info is a big resource for me, and I guide many of my patients there as well, because you do a great job pulling together resources across the state. So thank you for your work too.
Thank you. I hope you have a wonderful rest of your day today.
Thank you. You too.
Well, everybody, we talked about some really important things today, whether it is getting your healthcare power of attorney in place for April 16th, which is a week from tomorrow. You want to take a look at that, but also the real importance across the illness spectrum for palliative care. It was a lot of information, and I really hope that you have hit the like button and the share button to get this information out, because I know that you know someone who can use the information that we talked about today. It was just fabulous. I also did want to take a quick second. One of our faithful viewers, Carrie Lynn, it's her birthday today. So I wanted to say happy birthday to Carrie Lynn. She's 21 again. It's good to be 21 again. So in the meantime, everyone, I hope you have a wonderful week and that you be well and be kind.
If you like this video, please follow us on social media and subscribe on YouTube. For more information, visit rielderinfo.com or call 401-585-0509. If you have any questions, email deb@rielderinfo.com.